Hi, this is Joe Chaffin, and this is another Blood Bank Guy Podlet. Today we're going to do a 10-minute tutorial on why we leukocyte reduce blood products. And the truth is that things have changed a lot in the last 10 to 15 years. In fact, for most of us in the United States and Europe, this is really not a conscious decision. We live in an age of, in the United States, unofficial universal leukocyte reduction, whereas in Europe it is official that things are universally leukocyte reduced. But the vast majority of cellular blood products, such as those that you see at the bottom, whole blood red cells and both types of platelets, are leukocyte reduced. Leukocyte reduction simply means removing the majority of the white cells from transfused blood products, getting those suckers out of there. A multitude of reasons why we do this, but first let's describe why we need to do it. There's actually a lot of white cells that go along in these cellular blood products, and they're just along for the ride. They don't have any specific benefits. Let's look at red cells. So a unit of red cells has, on average, somewhere around 2.4 trillion red cells, which is obviously a lot, but in addition, there's about 1 billion white cells that go along with that, or 10 to the 9th white cells. Same thing with platelets on the bottom. A unit of apheresis-derived platelets have, by definition, at least 3 times 10 to the 11th, or 300 billion platelets. But in addition, they have somewhere in the range of 100 million or more, 100 million or more white cells. Again, a lot of white cells. They don't have any great effects, but we know that they can potentially have some negative effects, and let's talk about those. Certainly, we know that they have immunologic effects. They degenerate, they die off, they undergo necrosis and apoptosis as they sit in bags of blood waiting to be transfused, and as they die, they secrete substances into plasma, various toxic substances certainly, but also a bunch of cytokines, and those cytokines we are very familiar with as causing febrile transfusion reactions, especially in platelet transfusions. And there's debate and discussion and research into some of the other potential adverse effects that can happen. Also, we should know that those transfused white cells are responsible for presenting foreign HLA antigens to the host immune system. And this is an odd kind of counterintuitive thing. I'll show it to you in just a second. But the bottom line is that leads to anti-HLA antibody formation. When a recipient forms anti-HLA antibodies, they can have problems with future platelet transfusions, become refractory. They can have febrile transfusion reactions when they're transfused HLA incompatible, I should say, blood products. And down the line, they can have issues if they're going to undergo a stem cell or a solid organ transplant as a result of those HLA antibodies. And again, here's how this works. So we've got some platelets that are going to be transfused. Platelets carry HLA-1 and platelet-specific antigens, whereas the white cells that go along with them carry not only HLA class 1 antigens, but also HLA class 2s. And the class 2s are the big deal because it looks like those transfused HLA class 2 antigens on the transfused white cells are responsible for presenting those HLA class 1 antigens and platelet-specific antigens to the recipient so that you end up with a formation of anti-HLA class 1 antibodies, I should say, or anti-platelet antibodies. The reason we know this is if you take the same situation, you take away the white cells, in other words, if you leukocyte reduce, and that interaction with the host system does not lead to the formation of those antibodies. So it seems like the transfused white cells are responsible. In addition, the other immunologic effect that we've discussed in the past is transfusion-related immunomodulation, or TRIM. A big deal in the discussions in the late 1990s when we were talking in the United States about going to universal leukocyte reduction. We know that there's some evidence of increased risk of post-surgical infections and tumor recurrence, as well as reactivation of viral diseases and potential for increased short-term mortality after transfusion. That we know, but what we don't know is what causes it. It was postulated that leukocytes were the cause, but studies that have been done since essential universal leukocyte reduction haven't shown a clear decrease in the TRIM-related effects. We've talked before about the attack on host HLA antigens and transfusion-associated graft-versus-host disease. That's in a separate podlet on irradiation. I'll leave that alone for now. Finally, there are infectious risks from transfused white cells. Some viruses, such as CMV and EBV and HTLV, live in white cells, so as a result, can potentially transmit infection. And the prion discussion was primarily discussed in Europe, I should say, with the possibility of variant CJD being decreased, or Creutzfeldt-Jakob disease being decreased by universal leukocyte reduction. It probably doesn't happen, at least not completely. So here's transfusion-transmitted CMV. Notice that the the C for CMV is only in one of those white cells, that simply means that not all of the white cells carry CMV. In fact, a minority of them carry CMV, but the one or ones that do can go into a immunocompromised recipient and cause transfusion-transmitted CMV. Well, how do we get rid of these white cells? Well, there are two ways: filters or processes built into apheresis machines. And let's talk first about the filters. Leukocyte reduction filters, you see a picture of one up on the top left of the screen. They work in a couple of ways, and this is somewhat conjecture because the filter manufacturers are a little tight-lipped on this, but this is probably at least mostly true. The flow of blood goes along this way, and basically they first act as a barrier, just like you would expect for a filter. They have a pore size that allows red cells to cruise through, but does not allow white cells to cruise through, especially at cooler temperatures when white cells are less deformable. But in addition, it's not just a barrier, but it's also an attractant. This filter is built, the material is built to attract white cells either through charge or some other physical factors, so that the white cells get stuck against the filter. And that may cause even more of an effect than just the barrier method. It's more complicated than this. This picture from an article by Gorlin and Godino in Transfusion in 2001 really illustrates that with a scanning electron micrograph. I do want to show you, though, graphically how efficient filtration is. Imagine if you have 1,000 white cells, and this actually is, if you want to pause it and count it, is 1,000 white cells on our slide. If we leukocyte reduce using current methods, what we'd see is that those methods are at least 99.9% efficient. So we would only have one white cell left out of 1,000, and in some cases, 1 out of 10,000. It's a very, very efficient method of leukocyte reduction. Now, when we look at apheresis machines, such as the Amicus or Trima that you see here, they separate blood based on specific gravity, like you see in here. And so they can target the specific product. But in addition, for example, the Trima has a leukocyte reduction system that you see at the arrow here, which specifically eliminates leukocytes to an even greater extent and basically makes them as leukocyte reduced as filters do. So what do we end up with? Well, there's two numbers that you should be aware of. In the United States, a leukocyte reduced unit of blood has less than 5 times 10 to the 6, or 5 million residual white cells, by definition in 95%. That number in Europe is less than 1 million, but you should know that 99% or more of the products in the United States actually do meet the European standard. We just don't say that. When does it happen? Well, pre-storage is probably best. It's not really completely pre-storage. It's either at the time of collection or within 72 hours of the collection, basically before the product has a chance to be stored for a long period of time. Pre-transfusion leukocyte reduction is less optimal. It's done in the transfusion service or at the bedside. Thankfully, not very often at the bedside. Well, we've kind of built the background. Let's talk now about the indications. There's universal agreement that leukocyte reduction decreases the risk of febrile reaction in a history of a patient with febrile transfusion reactions, and that's because of the removal of the white cells, getting rid of this before the cytokines can be secreted, as well as decreasing HLA immunization. And that's the second one, that HLA immunization prevention in platelet recipients with hematologic malignancies that leukocyte reduction works for, and CMV transmission prevention in susceptible recipients. There's debate about that last one, whether it's as efficient as using purely CMV seronegative products, but that is a topic for another podlet, that is for sure. The other one that's recently well agreed on is the prevention of reperfusion injury in cardiac surgery patients, but that's still becoming known, but there is good evidence for that. There's also partial agreement on HLA immunization prevention in patients with non-hematologic malignancy. I talked about the TRIM effect prevention before. Some people say that using leukocyte reduction can decrease septic transfusion reactions because there may be some decrease in the amount of things like Yersinia. And TAGVHD, there may be some reduction, just like post-transfusion purpura, but it's not sufficient by itself. A couple of details that you should know: there's a lot of cost to this. Leukocyte reduction is costly, and the utility may be limited. The studies don't really prove a whole lot of cost savings. And there's some rare complications that you see listed there, especially the ACE inhibitor patients that get hypotension, but not much more to say about that. Remember, for TAGVHD, you have to irradiate the white cells to completely prevent it. It may decrease TAGVHD by leukocyte reduction, but it does not completely eliminate it. Finally, granulocytes can be irradiated, but cannot be leukocyte reduced. I hope that's obvious. Filter failures happen most commonly in donors with sickle cell trait. And I mentioned before that cold red cells filter much better than room temperature red cells due to the decreased flexibility of white cells at those temperatures. Okay, that's it for this 10-minute tutorial. I hope it's been useful for you. Thanks and have a great day.